Welcome everyone to this month's webinar, Medication Management. My name is Donna Greening and I'm a Programs and Services Coordinator at Parkinson Canada. I know you're eager to get started, but I wanted to go over a few items before we start. From coast to coast, we acknowledge the ancestral and unceded territories of Inuit, Métis, and First Nations peoples. We have enabled closed captioning for the benefit of attendees who may be hearing impaired. You can turn on or off closed captioning on your own screen by clicking on the CC Live Transcript button and then clicking on Show Subtitle or Hide Subtitle. Please note that this feature uses auto transcription, so there might be some spelling errors along the way. At the bottom of your screen, you'll see Q&A and chat buttons. If you have any questions, be sure to write them in the Q&A space. We'll have time at the end to answer some of your questions, as well as the ones that you submitted when you registered. The chat window is there if you want to talk amongst yourselves, but questions written into the chat window will not be seen by our presenters. Now let's get started. It is my pleasure to introduce to you Dr. Tejal Patel. Dr. Patel is a clinical associate professor at the University of Waterloo School of Pharmacy and is a practicing clinical pharmacist at the Centre for Family Medicine in Kitchener, Ontario. Dr. Patel obtained her Bachelor of Science in Pharmacy and Doctor of Pharmacy degrees from the University of Kentucky and completed a postdoctoral research fellowship in neurology at the University of Illinois. Her research and clinical practice focuses on the assessment, classification, and management of drug-related complications in older adults and in people with neurological conditions and cognitive impairment, including dementia and Parkinson's disease. Medication management capacity and adherence to medication regimens are of special interest to her, and we are very grateful to have her join us today and share her knowledge. Welcome, Dr. Patel.
Thank you, Donna, for that lovely introduction. I also want to thank Parkinson Canada for inviting me to present at this medication webinar and for you all to attend and listen to me. I'm especially grateful for your presence at this webinar. I'm just going to share my screen so we can get started. Okay, so today we want to talk about medication management in Parkinson's disease. And so over the next 30 to 40 minutes, what I hope to do is cover two primary objectives of this talk. The first really is to discuss the use of medications that we use for treating Parkinson's. And within this big objective, what I was hoping we could cover is, when are medications for Parkinson's disease initiated? How do we make decisions about which medications we're going to use? How do we decide how to dose the medications? So for example, how often you're supposed to take it in a day and how long you take it for. And then what are the expectations from the use of these medications? That is, what do we hope to achieve in terms of controlling the symptoms of Parkinson's disease? And what are some of the considerations for safety of the use of these medications? What kind of side effects do they cause? The second thing I was hoping we could talk about is review a little bit about the challenges we might have with taking medications at home. It's a complex process. You have to organize the medications, you have to remember to take them, and sometimes they're not the easiest things to take. So we will chat a little bit about that, and we'll talk about what are some of the ways we could address these challenges. So let's get started. How do we decide when is it the right time to take to start medications for Parkinson's disease? Where there's three different considerations that we think about when we're trying to determine if it's the right time or not. When is, of course, the question about when is the perfect time to start medications. And really, there is no perfect time. It is really dependent on one person, from one individual to the next. For example, often we decide where to start medications when the symptoms of Parkinson's are becoming socially awkward for individuals. That may be the point at which we might start medications. The other determination we consider for starting medications is what type of impairment in activities of daily living are the symptoms of Parkinson's presenting with? Is it making it difficult for someone to eat or to drive a car? Or is it making, the symptoms of Parkinson's making someone, making it more difficult for someone to put on their clothes? Those kind of considerations we might also use. And finally, when it comes to which medication, there are 3 or 4 different things we think of. The first is how severe are the symptoms of Parkinson's? The severity of symptoms really does depend or differ from one person to the next. So that's one consideration. Another consideration is what are the types of symptoms specific to Parkinson's that are presenting in an individual. And the last is, what is their age? What other medical conditions do they have? What other medications are they on? All of those factors can drive which medication we decide to use. So let's talk about the severity of symptoms. Often when we're looking at the symptoms that are presenting in an individual, we might classify them as mild or severe. And mild symptoms are symptoms that are there, they're present, but they're not really impacting a person's day-to-day activities. They're problematic for the person, but not so much that it really impacts how they live their or how they complete their daily activities. In other individuals, they may be very severe and they may be actually affecting their ability even to do simple things like brush their teeth or have breakfast. So that's what we're looking at, is how severe are these symptoms to try to gauge which medication we should start with. The next thing we look at is how obvious or problematic are the symptoms that they're presenting with. For example, we usually divide this into, does the person have tremor, or does the person have stiffness or slowness of movement, so bradykinesia? And that in many patients may help us decide which medication to start with. The last thing we look at is how old is the person when we start the medications. Are they a younger patient or are they an older patient? And there really is no cutoff for an age where one might say you're younger and another person might be younger. There's no specific age. When we look at, or I talk to different neurologists, they'll all give me different ages. Some think it's 60, some say 65, some say 70. So it really does depend on the person who's treating you and how robust or frail one appears to a neurologist in terms of the age. Then we also look at comorbid conditions. And when I say comorbid conditions, I mean other medical conditions that the person has. Does the patient or person have hypertension? Do they have heart disease? Are they on any other medications that may interfere with Parkinson's medications? How do we adjust those medications if Parkinson's medications are required? And which Parkinson's medication should we initiate with if other medications cannot be discontinued or changed? Now, in terms of the medications we use to treat Parkinson's, these are broadly divided into about 7 different classes. And they're divided into these classes based on how they work in the body. And I will go through how these medications work in the body. But as a clinician, what we do is think about the different medications in the different classes, because it allows us to think how they work and how they may work with other Parkinson's medications. So for example, the first class is monoamine oxidase B inhibitors. And within this big class, there are 3 drugs that are on the market in Canada: selegiline, rasagiline, and safenamide. Then there's a class of anticholinergics, and we have trihexyphenidyl and benztropine. We also have dopamine agonists, and included in this class, we have pramipexole, ropinirole, rodigotin, or apomorphine being the newest addition. We call levodopa, both the formulations of levodopa, those that have cinnamate with the carbidopa, and the other one is prolopa with the benzeseride. We call them dopamine precursors. The next class of medications that really has only one drug in it is called the COMT inhibitors. And then we have amantadine, which is an NMDA antagonist. And finally, there are some products on the market that combine entacapone, levodopa, and carbidopa together in one pill. So how do these medications work? Well, I mentioned the classes, and so I'll go through those classes. And let me just orient you to this picture first. So if everybody can see my cursor, this big red line, pretend that on the left of this line is outside the brain, and on the right of this line is inside the brain. And inside the brain, we have these things here. They're like little shapes, but what they're supposed to represent is your neurons. And this neuron is is separated from this neuron at the bottom. And what essentially we need to do is send messages from the neuron at the top to the neuron at the bottom to be able to have movement. So if the messages are delayed getting from the top neuron to the bottom neuron, then we may not be able to perform all of our motor activities as we would normally do. Now, for our drug, which is levodopa, to get into the brain, from outside the brain into the brain, actually levodopa gets in from outside the brain into the brain. In our body is something called dopamine. Dopamine does not get into the brain. It cannot cross what we call this blood-brain barrier. But it's dopamine that works in the brain. It's the dopamine that allows this neuron from this end of the neuron to that end of the neuron to talk to each other. Dopamine actually needs to filter through this gap to be able to make this neuron work. Now, because dopamine does not get into the brain, we give levodopa to people who have Parkinson's. And we give it with carbidopa or benzeseride. So carbidopa is cinnamate, and if you give it with benzeseride, it's called prolopa. Because these 2 components actually stop the breakdown of levodopa before it gets into the brain. So we allow more levodopa to get into the brain. The same thing happens with entacapone. It stops the breakdown of levodopa outside of the brain, so more levodopa can get into the brain. Once the levodopa is into the brain, we actually want it to be metabolized into dopamine, because it's the dopamine that's the effective part and allows the neurons to talk to each other. So inside the brain, dopamine also gets broken down, and it gets broken down by something called a monoamine oxidase inhibitor and also by COMT. So what do? We give people who have Parkinson's drugs that prevent the breakdown of dopamine inside the brain, so that more dopamine can be available to send messages from one neuron to the next. What we also do is give drugs called dopamine agonists. And those are the ones I mentioned earlier, the Requip, the pramipexole, the rotigotin or Nupro patch. Now, these are called dopamine agonists because they pretend to be dopamine. They sit on these little doors on the second neuron. And when they sit on those doors, or what I can say is that they're able to push those doors open for messages to get through. And we call these dopamine agonists because they sit on those doors and allow those doors to open. So really, all of the drugs that we use have one intention, and that is to increase the amount of dopamine in the brain or behave like dopamine in the brain. Now, when I mentioned that when we are trying to decide what to do when we're initiating treatment, we look at how severe are the symptoms. So if the symptoms are mild, a clinician or a neurologist may decide to start with the monoamine oxidase inhibitor, like selegiline or rasagiline, and most recently with safinamide. If the symptoms are severe, especially if there is a tremor, often clinicians will decide to go straight to levodopa. If the person is younger and tremor is the only predominant symptom that's presenting, not the only, but one of the most problematic symptom that's presenting, especially if you're younger, then clinicians may decide to go with a dopamine agonist or even an anticholinergic. Now, dopamine agonists and anticholinergics are not problem-free as we age. They cause more side effects as we age than they do in the younger population. So as we age, clinicians tend to move towards using levodopa for any type of symptoms, whether they're mild or severe. Some clinicians will move to levodopa regardless of what the type of symptoms are. And some clinicians, some neurologists will start with monoamine oxidase inhibitors, even in older adults, because they feel like then we have another option when things get a little bit worse. Now, what about dosing medications? So if you have Parkinson's, you know that you start with some medications and then you add medications, and sometimes other medications get taken away. And if you're on levodopa, it seems like we never have found the right dose. And that's because as we age, our Parkinson's progresses, and so we have to continuously adjust therapy to be able to control the symptoms of Parkinson's. Most medications are started at a low dose and then increased slowly over a few weeks. And this is to prevent the occurrence of a lot of side effects all at once, slowly acclimating your brain to the amount of either dopamine that we're increasing or agonism that we're doing, or pretending to be dopamine. Our brain needs to adjust to it. So we'll increase it slowly. We also don't want to start at the highest dose and increase the risk of the worst side effects. We want to increase it slowly so that we can stop at a dose where the symptoms are well controlled and there's not a lot of side effects, especially with levodopa. Some drugs, like the dopamine agonists, pramipexole, droperidol, are usually taken 3 times a day. We often do not go higher than 3 times a day for those drugs. The rotagodin patch, the dose may change per patch, but that's usually just given once a day. The apomorphine injections and sublingual films can be given up to 5 times per day, but the dosing of that is very, very specific to the symptoms that the person is having, and they actually require quite a bit of monitoring in terms of side effects. So we are very careful with dosing those medications. Levodopa combinations with benzaseride and carbidopa can be given multiple times per day. Some people say at max we should give it 8 times per day. I've seen neurologists go higher than that based on the symptoms that a person is presenting with, the severity of the symptoms, and how quickly the symptoms reappear at the end of the dosing period. Finally, monoamine oxidase inhibitors are usually taken once daily. Selegiline sometimes is given twice daily, but we often tell people who are taking these medications to take them before noon, because they can cause nightmares if taken after noon, and they can also cause sleeplessness. So how do we adjust treatment? Well, we usually monitor for how well the medication is working. So is it resolving the symptoms? Is the person who has Parkinson's able to live quite, functionally through the day? Are they having problems? That's how we measure effectiveness. And is it causing any side effects? Are they, causing problematic issues with the medication that makes us think that this medication dose needs to be adjusted. If it's effective and we have no side effects, the ideal situation is just to continue monitoring for symptoms in the future. If it's not effective, so there's not the response that we expected and we don't have side effects, well, if you haven't gotten to the maximum dose, the natural thing is to increase the dose to see if a higher dose will be effective. Or if you've already reached the higher dose, but it's not effective, the options include changing to another medication from a different class that I mentioned earlier. And the decision to change to another medication really is made collaboratively with the person who has Parkinson's and their neurologist. Sometimes, if we started with a monoamine oxidase inhibitor, we may add a dopamine agonist, or we may change to a dopamine agonist. Both of them are appropriate considerations, and it really does depend on the person. Similarly, if we had started with the dopamine agonist, we may add or change to levodopa. And if we had started with levodopa, and even at extremely high doses, it's not working, or we're not able to push the doses because they're causing so many side effects, we may then decide to add or change to a dopamine agonist. If a person presents with side effects or even motor complications, then we look at the side effect and we try to adjust dosing as long as the symptoms of Parkinson's remain controlled. Or we may start a drug to just treat the side effect. Often though, I try in my practice not to start new medications, because as soon as you start a new medication, you've got to think about a whole bunch of other things, including side effects from that medication itself, as well as drug interactions. But the idea is that you consider all options. Now, some terms we use in Parkinson's, and for those of you who have Parkinson's, I'm sure you're already familiar with these terms. Terms such as on, those are periods of time when people with Parkinson's experience a good response to medication. They have good function, good mobility. And then there's periods called off periods or off times. And these are times when the medication does not provide adequate control over the symptoms. Often on and off are very frequently reported with levodopa. It's very easy to see your on and your off periods with levodopa, but they can also occur with dopamine agonists. Then there's something called the wearing off. That we call that when the dose of medication that a person was on is not adequate. So for example, a person was taking 1 tablet of levodopa 3 times per day. And in the past, they could take it every 8 hours and it would work for 8 hours. But recently they started noticing that it only works for 6 hours. Well, we would call that a wearing off effect. Motor fluctuations. This is when the duration of the effect shortens and the person with Parkinson's starts to experience unpredictable or rapid periods move from on and off. So they were on for a few hours, then they become off for a few hours, then they become on, and we call those motor fluctuations. Persons with Parkinson's, especially on levodopa therapy, but also on some of the others like dopamine agonists and monoamine oxidase inhibitors, may also experience dyskinesias. And dyskinesias are these involuntary movements. They're very choreic or dystonic. And they often occur at the peak times of dopamine concentrations in the brain. And the last term that we also, I'll mention here, is called the impulse control disorders. And these are side effects or complications from using dopaminergic therapy that results in things like uncontrollable gambling or hypersexuality or binge eating or compulsive shopping. They're impulse or compulsive disorders. Now, in terms of adverse effects of dopaminergic drugs, I've mentioned motor complications, impulsive compulsive disorders. Nausea is a big one. A lot of people who are on levodopa will complain about that. And then also hallucinations. And these symptoms, like nausea and hallucinations, can present earlier. Hallucinations more dependent as you get older, the risk increases. With motor complications, we usually see it after about 3 to 5 years of being on dopaminergic therapy, especially with levodopa. Other adverse effects include hallucinations, constipation, and orthostatic hypotension. And it depends on which drug. For example, anticholinergics can cause more constipation, whereas dopaminergic agents such as dopamine agonists can cause more hallucinations or orthostatic hypotensions. And what that means is a drop in blood pressure when you go from a sitting to standing position or from lying to sitting position. And there's a bunch of things that we could do for each of these side effects. Often with hallucinations, if the symptoms are mild, we might consider not treating it. But if they become problematic, then we can start thinking about, which of the Parkinson's medications is causing these problems. Is it possible to reduce the dose or replace the drug? And again, those decisions can be made collaboratively with your neurologist. If a person has constipation, again, look at the drugs to see if there is a drug that increases that risk, and if it's possible to decrease the dose of that drug. And if it isn't, then we start thinking about, how else can we improve constipation? Actually, we should be thinking about that anyway. Improving dietary fiber, fluid intake, physical activity, stool softeners, or even drugs to treat that side effect or treat that condition called domperidone. Not the condition, the medication. In terms of decreases in your blood pressure, always do move positions, change positions slowly. So when you're going from sitting from a sleeping position or standing from a sitting position, do so very slowly, avoiding large meals, avoiding alcohol or excessively warm areas, increasing fluids. And this is one of the infrequent times I tell people to increase the salt in their diet so that their blood pressure can increase as well. If one has motor complications, one of the motor complications is we see no effectiveness with a good dose of Sinemet. Well, if that's the case, a neurologist may think, is this really Parkinson's? And he might investigate further. However, some people need really, really high doses to respond. So it might require some adjusting of doses before we decide that it's not working. If we don't get the response we're expecting, then the options that you can discuss with your doctor are, increasing the dose of levodopa or dopamine agonist, or adding or other medications to see if we can improve the response. If by any chance you've taken the drug, but it's taking a long time to start working, we may need to increase the dose of the medication. We may need to change the time of the administration, avoid the controlled release formulation, or we may ask people to dose it on an empty stomach. Now, with levodopa, that can cause a lot of nausea. So what I usually tell people is have a little bit to eat. I might try to find out what are they taking their levodopa with? Are they taking it with a lot of protein? Well, protein sometimes delays the absorption of levodopa and therefore may be impacting the delayed onset of the drug. If the person starts complaining of wearing off, then the options include, adjusting the dose. And we may adjust the dose by decreasing the dose per pill, but bringing the dosing closer. So instead of taking one pill 3 times a day, we might say half a pill 6 times a day. So it all depends on the person in terms of how we change the dosing. If the wearing off is happening overnight, so in the morning, a person with Parkinson's having a hard time getting going, we might use a CR formulation. We tend not to use the CR, the controlled release formulations, because they're very unpredictable responses. We can't really say how well they'll work often. So we try not to use it, but the one place we will often use it is at bedtime to give you some coverage through the night. Adding a dopamine agonist, if you're not on it, if we add it, then we always look to see, is it producing dyskinesias, and do we need to adjust the doses of other drugs that you're on, so that we can fine tune the effectiveness and the control of symptoms without causing any dyskinesias at higher concentrations of dopamine. And we also see freezing as a motor complication, and this is something that's really difficult to treat. If the person gets freezing during their off periods, it makes sense to increase the dose of levodopa or add a dopamine agonist or monoamine oxidase inhibitors. But my occupational therapy friends tell me other things that we can do that are quite effective are something called sensory cues and devices. So putting a marker on the ground that gets you going, stepping over a cane, or even singing or dancing to rhythm can get a person walking from those freezing moments. And if it's peak dose dyskinesia or a dyskinesia that you see after taking a dose, once the person has advanced disease, it becomes really, really difficult to manipulate the dose, because even small adjustments can put you into an off period. But really, the only options we have are adjusting the dose, reducing the dose of levodopa, or reducing the dose and adding a dopamine agonist, or increasing the dose of dopamine agonist. If you're on a CR formulation, often we'll move to a regular release formulation. We may try adding other drugs. So there's a lot of adjusting that needs to happen when someone presents with dyskinesias, and it all depends on which drugs they're on, what doses they're at, which drugs they've used in the past, and whether they've had side effects or not. Often in dyskinesias, we may use amantadine as an option too, because it's been shown to be effective for treating dyskinesias. Some additional things to think about. I'll try to wrap it up here soon. With nausea, non-protein snack, because protein decreases bioavailability. Fizzy drinks seems to increase the onset of effect. I often tell all the people with Parkinson's that I know not to discontinue their medications abruptly, because it can be quite dramatic in terms of the inability to have function or movement or mobility. I've already mentioned the controlled release, and then there's a bunch of drugs that interact with all the medications that are used for Parkinson's. I won't go through all of them here, but that's something that we need to be made aware of, or you should consider when thinking about these meds. I'll stop sharing.
Well, thank you very much, Dr. Patel. That was really great information. It really highlighted how important it is to work together with your healthcare professionals to make sure that the dosing for you is right, because you've got so many factors that are involved. So it really is a unique process to get the dose that's right for you. So thank you very much for sharing. That was really great information. So we're going to move on now to introducing Bryce Perry. He is Parkinson Canada's Information and Referral Manager. He is going to share some resources that can help you better manage your Parkinson's medications. And at that, when he's done, we will move on to some questions and answers for Dr. Patel. Bryce Perry was diagnosed with Parkinson's disease at the age of 42. In 2018, he hosted a golf tournament in support of Parkinson Canada and has become a strong advocate for those living with Parkinson's, encouraging them to live their best Parkinson's lives. Bryce has a YouTube channel where he shares strategies for managing everyday life with Parkinson's, and we are thrilled to have him join us on staff. Welcome, Bryce.
Thank you, Donna, and thank you, Dr. Patel. That was excellent. And I was actually getting really excited to see that next slide on the medication or how to handle it at home. So maybe if I wrap up a bit sooner, we could pick that up. But so happy to be here today. As Donna mentioned, I am the manager of information and referrals for Parkinson Canada, and it's a new position. I just got started. But to quote an old commercial, not only am I part of the Parkinson Canada team, but I'm also a client. So as Donna mentioned, I'm 51 years old and was diagnosed with Parkinson's about 10 years ago. So I thought maybe I would just share a little bit about my story and a bit about my medication challenge. And then I'll share some resources that are available to you that can help manage medication and get information on questions answered. So as I said, I was diagnosed with Parkinson's at about 40 years old, or 42 years old. When I was about 40 years old, right after my 40th birthday, actually, I started getting a twitch in my right pinky, in my right hand, and didn't quite know what it was, and just thought maybe I had too much coffee or too much caffeine that day, or maybe I was a bit stressed out or a bit nervous, or whatnot. And as a few more days progressed and it kept going, it was still there. So it was quite concerning. And as many people that have Parkinson's can probably attest to, it took me about 2 years of going from neurologist to neurologist to try to figure out what this was before I was finally diagnosed with Parkinson's. After 1 or 2 trips to 2 different neurologists and many different tests and a battery of tests, actually, with this, it had sort of progressed on the right side of my body to a point where I kind of had given up trying to get diagnosed, or it's not diagnosed, but trying to figure out what it was. Still shaking, still tremors. Tremors had kind of increased on my right side, and I'd kind of given up. And one night I was lying in bed, and my toes curled up on my right foot, and curled up so hard that I could not uncurl them and get out of bed. So again, went back for another trip to the neurologist. And when I was finally diagnosed with Parkinson's, it was quite of an interesting feeling, because I was actually more relieved to know what it was than I was nervous or scared about the diagnosis. So after kind of going through this process and then realizing that, wow, I've got Parkinson's, and now what, and what's the rest of my life look like? It was quite disheartening. I was, again, 42 years old. I had quite a job with a lot of responsibilities. I was manager of many people in a large corporation, and at 42 years old, I was trying to figure out, what's the rest of my life look like. So my medication side of the journey, my neurologist started me on some levodopa and whatnot. And what was quite interesting about it was that, when you take, as an example, when you have a headache, let's say you take Tylenol and you expect that headache to be gone. And when it's gone, you feel great. One of the things that I was quite disheartened about at the time with medication is when they started me on my levodopa, I immediately, well, not immediately, but within a few days, all of a sudden I started feeling a bit looser and feeling a little bit better. But then within about 3-4 hours, it went back to normal. And that's when I was reading all the different things on the internet and trying to find information on this, and talking to my neurologist and talking to my family doctor, and trying to figure out why, why can't I just get this to stay away? So we started increasing the dosage a little bit and decreasing the time between dosages, trying to really get to that nice on, as we call it, on and off, trying to get on. I wanted to be on all the time. I remember what was really shocking to me was with medication was when I was told, and I went back and they'd always, my neurologist would say, how do you feel today? How you've been feeling? Do you feel 50% as good as you used to, or 60%? And at the time I was probably feeling 50-50, maybe 50% normal, if that's the right way to say it. So we, again, went back and we added some drugs and some different things to it to try to increase the on period and whatnot. But I wanted to feel 100%. I wanted to feel just like I used to feel. When I got to about 60-70%, my neurologist said, great, we're going to hold it right there. And I said, well, no, I don't want to feel 60, 70% as good as I should or as good as I used to. And, he said, no, we want to keep you at 67% because we want to keep the side effects down, and try to extend that. So it was quite interesting at the time, was disappointing. Now, after I've been on medication now for going on almost 10 years, I'm very happy that I was able to get to a kind of a peak performance. And what I mean by that is, the least amount of medication I could take, the least amount of times a day to feel 70 or 80% well. Because after 10 years, I have not yet developed or severe side effects to the medication. So, looking back now, I'm very happy that we did it that way. One of the things I find with medication, though, is what I find challenging is, and what I would recommend, and what I recommend to people that I speak to, is to have a real strategy when it comes to medication. One of the things that is very easy for us is to forget to take them on time, and to forget to take our dosage when we should. And it's very important for a person with Parkinson's to maintain and keep that medication at the on time. You want to keep that level up, because those on and off periods, the off periods, can be disheartening. Now, for a person with who's diagnosed younger, that became a real challenge for me, because I was a speaker, I was doing presentations, I was had staff to manage, I had people to be around, and I didn't want to be shaking, I didn't want to be tremoring, I didn't want to feel stiff around them, or them to see me. Maybe it was more of a pride thing. I'm not quite sure at that moment what exactly that was, but you want to ensure that you're feeling as good as you can be, and hopefully, this might sound weird, but hopefully where people don't notice. So I would have pills in my pockets, and I would try to be taking them at the right time, or the appropriate time. Or if I was in a speaking environment where, for 3-4 hours and I couldn't take them, I had to, I thought that maybe if I took extra levodopa before I went to do my speaking presentation, that would prolong it longer. What I found out was that, taking too much levodopa is going to, give you that side effect that you're going to be, be shaking around. So now here I'm trying to take medication, and, to prevent shaking and moving and whatnot, and tremoring and stiffness. And now here I have gone and overdone my levodopa to try to self-medicate myself to get longer. And now I'm in my presentation and I'm swaying and I'm moving, and it was quite a different experience. So, one of the things that we have to do is think ahead and think about, what does our day look like, and what are our timing, and do I maybe need to adjust my dosage, maybe do it, start an hour later to try to make it fit in. So there's a great strategy involved in ensuring that we're taking the right type of medication, or the right types, the right times, and getting that medication when we need it. Some of the things that I experience when I'm coming off my on zone is, I start getting lightheaded, I start getting headaches, I start feeling maybe a little off, I start feeling, some people call it, they say sometimes I look very tired, or that I look like I'm zoning out. And I realize at that time that, hey, I maybe I haven't taken my medication, maybe I'm taking it on time, and maybe I'm not doing it in the appropriate amount. So those are things that I personally, this is just personal experience I'm talking from. Those are the things that for me are indications to me that I need to take my medication. One of the things that I was unaware of at the time was, I thought when my neurologist, my doctor, said prescribed, take 3 pills of these, or, every 3 hours, that meant that I had to take it every 3 hours. What I've come to learn, and through my doctors, and even with my personal experience, is to, there's some days that my off periods, my on periods can seem longer, and that's okay. And so I can stretch out my time, because I've become used to it. I know when it's coming, and I know how to do it. Or I can, if all of a sudden, I'm normally taking my medication every 3 hours, and at 2 hours in, I'm just not feeling it. I'm just feeling off. I'm just not feeling myself. Then I can take my medication. So you have to really come up with your own strategy, and you have to, again, and working with your neurologist, working with your experts or your healthcare team to really come up to understand what's right for you, I guess I should say. But one of the things that, and I'll give you some of the little tips and tricks that I've done, and some have worked and some haven't. I find it very interesting that I always tell people when I try to describe it to people, I kind of say it's sort of like the Tin Man from the Wizard of Oz. That Tin Man is just like stuck and stiff and barely moving, and Dorothy walks by and she squirts the oil on the Tin Man, and he can slowly start moving again and start getting more active. And so to me, that's how I describe my feeling when I'm off and on. When I'm off, I'm stiff, I'm tight, I'm rigid, I'm again, not focusing, not concentrating, I'm zoned out. So that's my off period. One of the things that I experience also is first thing in the morning is really very, very, very stiff, very, very rigid, very, and no offense to any older people on the call, but I always say, like, I feel like I'm a 100-year-old man when I'm getting out of bed. And so I had to develop a strategy for that, because when you're very rigid and stiff, and you get your medication and all your medication, it's very difficult to open a lid of your medication. So I have to get my early morning dose on my nightstand done the night before, because in the morning it is very difficult for me to get lids off of pill bottles, which again is it's a strange phenomenon, right? Because I can open pill bottles all day long. First thing in the morning, I can't. So you have to develop those strategies. And to live your best life with Parkinson's, you have to come up with those strategies. And not every strategy is the same for everyone, right? So you have to come up with what works for you and what works best for you. So, for me personally, I get my medication, my morning dose ready the night before, because it's just easier for me to be able to take it and get into that 20, 30 minutes later and feeling my 60%. One of the things that I struggled with was that timing, and was making sure that I took the pills when I had to take them. And I've tried many different things. I've tried apps on my phone. I've tried, writing notes down what time I took my pills. The thing that works for me now is I just set an alarm on my phone, and when it goes off, I take my pills, take my medication, and then when I do that, I actually hit the button and reset it again. So for my next dosage, and normally again, you'll know, your body tells you when you need it, but it's always good to have those reminders. And then we're told often to, that you should have a full glass of water, you should have an empty stomach, you should have, and whatnot. Again, for me personally, and this is again just me personally, my morning dose is on an empty stomach, and I can take it with my coffee. Not a big deal. My nighttime dose, I can take it with tea. I can take, with a full stomach, without a full stomach. I'm totally fine with that. But what's interesting is my dose that I take right around the lunch hour, around 1 o'clock, if I don't have some food in my stomach, or I don't take it with, or I take it anything other than water, then it makes me very nauseous. So you really have to know what works for you. You have to understand what it is and what your triggers are, how it's going to affect you, and be able to roll with that. So, and one of the things that I really want to point out today, and again, like I said, I'm the manager of information and referrals for Parkinson Canada, and you may or may not know this, but we actually have a 1-800, a toll-free national line in Canada that you can call with any of these type of questions. If you have questions or that we can help you with, it's available to you 24/7. You can leave a message, we'll call you back. But we have people manning those phones and manning those lines to be able to reach out to and answer and help guide you, help give you some answers that you might need. And I want to really encourage you, if you don't know about that, I believe that they're going to put the 800 numbers on the side of the screen, and whatnot, and then you'll also get an update in an email afterwards. And some of the resources that we have, which I'm really excited about, is, and Dr. Patel alluded to in her presentation, is we have the medication booklet. So there is a link that you'll see on the side to a medication booklet, all different medications, what they are, what they are, the symptoms, and what you might look at. Now, I will caution you though, it's a very intense book, and it was really made for the healthcare professional. So if you want to do a deep dive and get very confused with medication terminology, that's your book. If you don't, and if you're like me and you just want to know, hey, what is this drug? What are the side effects, or what are the symptoms? Well, we've got a great new tool for you, and it's a searchable database. It's very, very simple to use if you're not technologically inclined, and like I am. And there's a link there, and it's a searchable database. You can go by symptom or by drug. It'll tell you kind of what they work well with and what they don't work well with. And that's a resource that we have. It's brand new, and we've developed that for you. So make sure you take advantage of those resources, and really go through them, and really advocate for yourself, and really understand, and you can answer a lot of questions. Again, though, if you need any help, need any assistance, any help with things in your community, or any questions and help with Parkinson's, make sure you take advantage of our information referral helpline. It is there for you. And I want to thank you so much for joining us today. And with that, I will turn it back to Donna.
Thanks so much, Bryce. Now, in the interest of time, we are going to move right on to the question and answers. So there was quite a few questions that were submitted asking about levodopa, other medications and supplements. So Dr. Patel, could you speak on if there's any medications that should not be taken at the same time as levodopa?
So there are some medications that can decrease the effect of levodopa in the brain. There's a particular class of medications called antipsychotics, and there's only one amongst those antipsychotic class that we would use with a person who has Parkinson's, because what they do is they block those doors. Remember, I mentioned that you have some drugs that open doors. Well, these drugs come and put big bars across those doors and don't let the dopamine get through. So that's one class of medications that you have to be aware of. The other medications can potentiate, so increase the effect of levodopa. Those also we have to be aware of. Some of those include medications like blood pressure medications. In our younger years, we're diagnosed with hypertension often, and we're placed on these medications to control blood pressure. But once a diagnosis of Parkinson's is made, Parkinson's can produce decreases in blood pressure and can cause orthostatic hypotension. So if you're already on blood pressure pills, that can potentiate the effect of those medications. So there are a few classes. I won't go through all of them because there's quite a few numbers of medications. What I would recommend is, if you are thinking, is this drug interacting with my medications for levodopa, is one, speak with your pharmacist. Make sure that they know what you're taking and they can explain it. And if they're not able to, make sure you speak with your neurologist and have them go through the whole list. I also tell all my patients to bring me everything that they're taking, even over the counter and natural health products, because we never know. If we don't know what you're taking, we don't know how to assess the interaction.
Great. All right. And we also had some questions, because it's cold and flu season, about what over-the-counter medications are safe to take.
So again, my advice is going to be, talk to your pharmacist before you pick up anything over the counter. There are a few classes of medications I tell all the folks that I care for with Parkinson's that they should likely bring to my attention before they take it. And those include, medications for congestion. Some of them have products or drugs in them that increase blood pressure tremendously, and others have what we call anticholinergic effects. So if you're on an anticholinergic for Parkinson's, or you're older and cannot take an anticholinergic, those can make memory difficult, can make constipation worse. So there's a whole slew of medications, and I can't go through all the different names. What I would say is pick that up, anything for cold and flu, go over to the pharmacy counter and say, I have Parkinson's, I am on these medications. Is this safe for me to take?
Great, thank you. Could you speak on the timings between taking your medications and meals, particularly with protein?
Yeah, so if you're taking a meal that is heavy in terms of protein, what I tell my folks is take the levodopa an hour before the meal or an hour after the meal. So separated at least by an hour. What it does is it decreases, or it prolongs the absorption So you don't get the same effect you would with that dose if you take it with lots of protein. Excuse me.
Okay, great. Thank you. There were some questions about the duodopa pump. Is there anything that you can share about it, such as what are the differences between using duodopa versus Cinnamate?
So the duodopa pump essentially is Cinnamate in a liquid formulation administered continuously. So whereas with the oral formulation, you're taking a tablet, you're waiting for it to get absorbed. And what it does in your body is it causes this big jump in levodopa, and then over time it goes down. And that's why we see the, coming on and wearing off feature. With the duodopa, what it's doing is it's giving you a continuous infusion of an amount of levodopa, so you don't get the peaks and the valleys, the mountains and the valleys during the day. However, before you can take duodopa, you have to have, first of all, there's only a few centers that will actually do the surgeries and infuse and put a tube into your intestines that you can take the duodopa with. So it is not without risk. You have to meet with a gastroenterologist. You have to meet with a neurologist. They have to decide that you're the right person to undergo this, that you can carry the risk for the surgery, and that you're able to clean the site, exchange the pumps, make sure that your infusion stays adequate. All of those risks have to be considered before a person can be placed on that pump.
Thank you. We've got time for just a couple more. We've been asked, are dosage modifications done solely by neurologists?
So usually it's a neurologist. Now I'm a pharmacist and I often adjust dosing, but I usually do it with the physician that is looking after the person as well as the person. And what I do is I have, people with Parkinson's or their care partners track what's going on with their dosing. So, when does the symptom come back? How long is the patient on for? When does it become off? Is there wearing off? And I look at all of that to try to adjust dosing, but I do it with the person who has Parkinson's, their care partner, and a physician who's involved in the care, so that we're all on the same page about how to adjust dosing.
Great. Is there a maximum dosage of levodopa, carbidopa that you can take daily?
So some, people might say 8 tablets a day, but often I've seen neurologists go higher than that. It truly is dependent on the person. We often start with about 1 tablet twice daily, and over over the years that a person has Parkinson's, 20, 30 years, we see it slowly increasing. Some people use up to 10, some people use up to 12. Truly does depend on the person, how well their symptoms are controlled, how frail they are, what kind of side effects they're having.
Thank you. And what action can people take if the doctor who is prescribing their medications retires?
Oh, well, the best option is to find someone else who can take over the care of your Parkinson's. It truly is necessary to have a person who understands Parkinson's, and usually that's a neurologist and a movement disorders specialist. If that's not possible, then I would speak with my family physician and encourage him to become versed with looking after Parkinson's.
Thank you. That's all the time we have for questions today. Thank you so much for answering them. Those were really, really informative. I wanted to thank everyone for attending today's webinar, and a very special thank you to today's presenters, Dr. Tejal Patel and Bryce Perry. I hope everyone found the information very valuable. The resources that were mentioned throughout the presentation and in the chat window, and a link to a recording of the webinar are going to be included in a follow-up email that we're going to send you. Now, we have something very special planned for our February webinar. It's going to be different than our typical webinar. We are going to be discussing the positive impact that exercise has on people with Parkinson's, along with opportunities for you to try out in some mini sessions some of the exercise programs. It's going to be on Wednesday, February 23rd, so watch your email inboxes for more details and a registration link. Thank you so much for joining us and enjoy the rest of your day.